looking at these two things, I think they form the maximum number of surgeries that are being done in ophthalmology. First being cataract and second being refractive surgery. Today, refractive surgery is basically from the perspective of occupational health, something very, very important. Like if you have pilots, you have people who are in the forces, you have railway drivers, you have people who have even NASA has recognized refractive surgery as something which is allowable. So there are news readers, newscasters, etc. So there are occupations where a person, for example, you're doing scuba diving, you do deep sea diving, etc. So there it is an essentiality to get rid of your glasses because they do come and cause encumbrances vis-a-vis the discharge of your normal functions. So today, cataract and refractive surgery, India today does the maximum number of cataract surgery anywhere in the world. We do close to about 70 lakh cataract surgeries a year, which is more than US, Europe and China put together. So those are actually great numbers that Indian ophthalmologists are doing. And I think nowhere in the world is cataract surgery being done at costs which are really very, very low for people who cannot actually afford the cataract surgery. But let us now come to something as to what has changed in cataract surgery. Today, cataract surgery has changed from being a restorative surgery, that means from getting a person just back to vision, but to also a refractive surgery where we do get an opportunity at the time of cataract surgery to give a person a good uncorrected vision also. Now, the latest that has happened in cataract surgery is the use of what is known as a femtosecond. A femtosecond laser is essentially a time and which means that it is 10 to the power minus 15th or 1 quadrillionth of a second. That means that the laser is a very high pulse laser or a high intensity laser that is fired, but it is fired for a very small period of time, which is 1 quadrillionth of a second. So therefore the total power, which is energy per time, because the time is so low, the total power that is delivered is very less, and because it is so well focused, it does not cause any damage to the non-target tissues. It only causes the release of energy at that particular point, and therefore today a femtosecond laser is the new cutting tool that we have. Now, if you look at a femtosecond laser, you have, say, a 1 micron of a laser beam, a high intensity pulse that is fired on the target. Now, you can focus it through anything that is clear. So, if you have a clear medium, the femto laser can penetrate, and this is looking at the femto laser within the cornea. So, if you are looking at a particular plane in the cornea, the femto laser will fire, and once it fires, it goes on to produce what is known as a bubble or a plasma, which is water plus carbon dioxide. So you have this creation of this plasma bubble which expands, and as it expands in this particular thing, you can, by stacking these bubbles or these pulses one after the other, create what is known as a cleavage plane. So this is how the femto works. So it's like a knife. So it keeps on hitting at a particular level and it creates a cleavage plane, or it can go vertically down and it can slice through things. So this is the thing that the femtosecond does, and the femtosecond laser has today made the cataract surgery go and look like a refractive procedure. That means the outcomes need to be repeatable in anybody's hand. That is the most important thing which we are looking at in a femtocataract surgery. And in a femtocataract surgery, the cataract surgery, there are 4 parts of the cataract surgery which I will be showing you, which are done by the femto laser. Rest, putting of the lens. As before that, the sucking of the broken up pieces of the cataract is done by the normal phacoemulsification procedure. So whenever you have a lens which you saw in the anatomy, the lens has a capsule. जैसे फल होता है कोई, उसका छिलका होता है, so similarly there is a capsule. You have to make a round opening in the top of the capsule, that is the interior part of the capsule, break the cataract into small pieces and suck it out through a small incision. And then you are retaining the posterior capsule, and in this bag that is emptied, you are putting in an artificial lens. So from exactly the same place from where you have taken out the nucleus of the cataract, the rest of the cataract, you are implanting a lens. So the first step that the femto does is to do what is known as a capsulorhexis, which is the front top opening. Now at times when you have a swollen cataract, I'll just show you, it becomes very, very difficult to get a round or a good capsular access, and if there is an extension in this capsular opening, you can have complications in the surgery. So the first step that the cataract by femto that is done is the capsular access. The second step that is done is to chop the cataract into very small pieces. So this laser goes and without release of energy in the non-target tissue, it actually slices the cataract into small pieces. The third thing that you do is to create the incision of the cataract for the cataract, and the fourth is that if there is an astigmatism, if there is a small cylindrical power, for large cylindrical powers, you put toric intraocular lenses which have both a sphere and the cylinder. But for up to a diopter or a diopter 0.25 of cylinder, you can make relaxing incisions in the cornea with this laser to release the astigmatism. So the first thing that the person has to do, these were the steps in which the laser works. But the first step that you have is that if you have the incisions, they have a better wound architecture. They can be planned accordingly, and therefore the wound is more secured. Now this is what we are talking about, was the capsular access. So if you see the picture on the right of yours, this is showing a perfectly round capsular access, and this is a one which is made by even an experienced surgeon by the hand, by a needle. So if you get a perfect rhexis, the lens would be placed better. The effective lens position throughout life is likely to be better as compared to a opening which is made freehand. The second thing is that you can do fragmentation of the lens. So in this case, this is fragmentation of the lens into 4 pieces. You can make it into 6, you can make it into 8, and you can even do softening of the lens, which I will show you. So what this does is that the lens has always been pre-chopped. Already a pre-chopped lens, if you have to aspirate it out by phacoemulsification, you need less energy, because you have already liquefied the lens to a great degree. And this is the other one, the fourth one, which is if you have cylindrical power, you can make incisions in the periphery. These are the 2 incisions that you have made in the periphery, and these incisions can reduce the amount of astigmatism. Now, when you are looking at difficult situations, I'll just show you situations in surgery. If you have a white intumescent cataract, that means the patient has waited for long enough and not got the surgery done. Getting a capsular access is a problem. So this is on the femto. One of the integral parts of the femto is an imaging technology. That means it is an in vivo image of the cataract or the front part of the eye that you get and plan your surgery at that time. So this is done by a machine called as OCT, or an optical coherence tomography. So this is an image of the front part of the eye that you have, which is shown here. So you can see here that this is the suction that has happened, and this is the capsulotomy. You can say this is the laser, and could you see that like an explosion? So this is what is called as a fluid cataract or an intumescent cataract, where the capsule was hypermature, the cataract was hypermature, and there was intumescence of the nuclear of the cortex, and therefore there was a huge pressure on the capsule. So what you can see is that if I was doing this with the needle earlier, then I would not have been able to do a round perfect capsulotomy. So you can see there is a round perfect capsulotomy that we have. The cataract, despite it being white, you can see that it has been pre-chopped. You can see that this is pre-chopped, and this is now the phaco technology that is being applied to a pre-chopped nucleus, where despite it being a hard brown cataract, you are able to get a good, better aspiration of the cataract. So this is the cataract being aspirated. Once the cataract has been aspirated, the cortex is aspirated, and this is the foldable intraocular lens which is implanted into the same position from where the cataract has been taken out. So you got a perfect capsular access, you got good breaking of the nucleus, and you got good outcomes. Now this is again, you can see in this particular case, this is again a hypermature cataract, actually a cardiologist who came to me, and you can see a swollen cataract, and you can see again a lot of fluid from the intumescence that comes out. This is the LRI that has been created for the astigmatism control, and you can see this is the primary incision and the secondary incision. So here again, despite it being a white cataract, we got a great capsular access which has been done, and we are able to crack the nucleus and remove. So this is now a crystal lens, which is an accommodative lens, which did not give that much of hope, as we had thought that it will take care of the near adhesion, but then you can go ahead and complete this surgery. Now there are certain other challenging cataracts which you have, which is called as a polar cataract. Normally, if you are not having an imaging device, you can err, and you can actually, because these cataracts are prone to having a dehiscence of the posterior capsule. Now I will just show you the advantage of a OCT guided femto laser. So you can see in this particular case, we are docking the eye, and we are getting the OCT image. So this is the front part of the cornea, the back part of the cornea, this is the anterior part of the lens, and now you will see the posterior part. I am just pausing here. Now if you look at it, this is, can you see this? This is a pre-existing defect that I have been able to find out on the OCT. So I am much wiser that this cataract is going to have a rupture here of the posterior capsule the moment I remove the nucleus. So therefore, I will be able to plan my surgery. So how do I plan my surgery? This is the laser setting. So I have taken up these beads. That means that the laser will act only in this area and it will leave this area untouched. So we will be able to break the cataract into small pieces, which you are seeing is happening only above the posterior capsular defect. And this defect, you can see this is already down, this is broken into small pieces. You have a good capsular axis that you have in this particular case. And we will only reach the posterior capsular defect when we need to reach it right at the end. So you can see this is a pre-broken nucleus, and we are, without being requiring to do any hydrodissection or rotation of the nucleus, we are able to take out this nucleus. You can see it goes on very well, and you can see this white ring that is pointed out. This is where the posterior capsular defect is. So I have only, because I could see, I have broken the nucleus or chopped the nucleus above the defect, and the defect is still tamponaded by the cortex and the epinucleus which is there, and it is only towards the end that once I have removed the nucleus that I am going to remove the epinucleus, and you will see, I will show you that there is a defect which is pre-existing. we are doing the cortex removal now, and it is only at this particular point, once we are at the end of the surgery and doing the cortex removal, you can see that this huge rent comes into play. If I was not doing a femto, so can you see this huge rent? So this rent was pre-existing, I knew about it, so I could prepare it, and accordingly in the surgery I was able to get a great outcome in this particular case by putting a 3-piece lens. So there is another technology which is called as a Zepto technology. So doing a good capsular axis is something which is very important. In this, I don't believe that this is the best technology, because the eye is open when you are doing a capsulotomy. So you are putting this, there is a radio frequency current that will be passed through this nitrilol loop, and then you can get a good capsulotomy in this particular case. So you can see this here, and that is the bubbles that are formed after putting the suction, and that is there, that is all that is required for doing a good capsulotomy. So this is again another technique that you have for doing the laser vision, the capsulotomy. Now let me come on to the second thing. So advances in cataract surgery, the latest is the blade free femto cataract assisted robotic surgery, which gives you a lot of information at the time of the table, in vivo information, so you get better outcomes. Now you have, when you are putting in an implant into the eye, the implant was usually having one focal length. Now this one focal length gives you a monofocal vision or a uniocular vision. That means that it is for a distance vision that you have, and for near you were supposed to have the reading glasses. Now the problem that came, that like in the glasses you were having multifocal lenses where there were rings in the lenses which you could implant in the eye, but a lot of them had dysphotopsia or photopic phenomena, because wherever there was a junction you could have a glare and a halo, and there could be edge defects, and because what happens is that in a multifocal lens there are 2 separate or 3 separate foci. So light is divided into these 3 components. That means at any given time there are 3 foci within the eye. In a monofocal lens, 100% of the light is used for only one foci. Therefore, the quality of vision, especially in dim light and low contrast, is always better in a monofocal lens as compared to a multifocal lens. So there were a lot of dysphotopsia, etc., and contrast sensitivity was a problem that you had in these. And then came in the accommodative lenses, which are supposed to, which I showed you, a crystal lens, which are supposed to change their focus as the eye tends to, the ciliary body tends to contract, but they have not held up to the promise. So again we are back to having different zones within the multifocal lens which is there. A new concept that has come is called as an extended depth of focus. I'll just show you what I talked. So when you are looking at a monofocal lens, all the light is coming to one focus, 100% of the light is being used at one. When you are coming to multifocal lenses, there is one focus. So let's say if there's a bifocal lens, there is one focus here and there is one focus here, and light is split into two parts. But when you are looking at the EDOF lens, which is the symphony lens, you are actually creating a conoid. So the person can see good here also and good here also, but there are no two defined foci that are there, and therefore the amount of dysphotopsia that you have is much less. And these are basically the EDOF lenses, which again I am trying to show here, monofocal, single focus, two distinct foci in multifocal or bifocal, and in an extended depth of focus, the patient will be able to see from here to here. So these are lenses where the photopic phenomena or the dysphotopsia of glare, halos, loss of contrast goes down significantly as compared to the other cases. So this again you can see is a pre-chopped lens. You can see this is the incision that has been made. We are just opening it in the blade free. The capsulotomy has been done, the nucleotomy has been done, the capsule is removed, and you can see the amount of energy that we are using with the phaco is much less. This is the cortex that is being removed, and now you are putting in this EDOF lens, which is, you will just see in this particular case, once the lens is opening to its full size, there will be few rings that will come into play, and this is what gives you the elongated depth of focus that you have in these patients. Now another lens which is again taking making waves is what I call as the trifocal lens, and this is actually giving both intermediate, near and distance vision. Normally we do not have any difficulty in prescribing them to housewives because they don't do night driving. That is the time when the symptoms come, and they are not that dysphotopsic because they're wanting that quality of vision may not be. So they will give you a reduced dependence on glasses for all distances, but there could be some amount of dysphotopsia. So the brain does adapt to this dysphotopsia. So it is a choice we give to patients. As of now in our practice, about 10% of the patients are going towards the trifocal lenses or the EDOF lenses, and these are because there are new things that have been done which is giving you various advances in reducing the dysphotopsia. So this is what I wanted to talk about, and there is one more lens which I talked about in brief, is called as a toric lens, which is now very often used if case there is a cylindrical power, like if somebody is using in your glasses a sphere and a cylinder and the cornea is showing a cylindrical power, then you should go in for a toric lens because there are no dysphotoxic phenomena and the cylinder of that patient also gets out when you are doing a cataract surgery. Now let's come to the second thing, which is called as the refractive surgery or the laser vision correction. The first thing which started way back about more than 25 years was the conventional LASIK. LASIK stands for laser in situ keratomileusis. That means laser, you are using a laser in situ, that means within keratomileusis to reshape the cornea. Kerato is cornea. So you are using a laser within the cornea to reshape it so that the need for glasses changes. So what happens is that if there is a curvature of the cornea, if you remove certain tissue in the center, it flattens. And if it flattens, the minus power requirement goes down. If you do laser in the paracentral area, it steepens, and therefore the requirement for a plus power glasses goes off. And if you have removed the tissue in a circular manner, then it will take care of the sphere. But if you are removing it in an oval fashion, it will take care of both the sphere and the cylinder. So that is what is conventional LASIK. And then the femtosecond laser, which I talked about you, that came in, which made the laser into a blade free LASIK. So what happens when you are doing a LASIK is that you first create a flap in the cornea. That means if this is the cornea, you make a flap in the cornea, do laser and put back the corneal flap which binds on its own. So there are two-step procedure. One is to create a flap and the second is to burn the tissue by an excimer laser, so that which is reducing the power of the cornea. And the third is what is the most important, or what is today is called as a SMILE procedure or a small incision lenticule extraction. As in cataract surgery, we have gone to a small no stitch cataract surgery, like we have gone for laparoscopic cholecystectomy, etc. Wherever the incision is small, the healing is faster. So therefore we have today the SMILE procedure which is there. And in the SMILE procedure, instead of burning the tissue by an excimer laser, you have a laser which is first moved at a particular level here. Then you cut a lenticule like this, and then you create a cap, and then you make a small lenticule, small side port incision, and you will remove this lenticule rather than burning it. I'll just show you a video. So this is the Femto Laser. As I told you, we have docked the eye. After docking the eye, this is the laser which is moving on the under surface of the lenticule. आपका पावर जितना है उसके हिसाब से thickness of the lenticule will be decided. So you have the under surface of the lenticule, you have cut the side, and now you are coming on the over surface of the lenticule, and this is the 2 millimeter side cut. So you have created, like if you have a loaf of bread, you are taking out one piece of bread from it. So this is, you have gone below, you have gone above, and you have created a side port. Now we go into the side port, the laser has done its job. The only thing, as I told you, there are multiple spots that have happened, that cleavage plane needs to be joined. So we are going in with a blunt spatula. With this blunt spatula, we will go into both the layers. So first of all, we are going above the lenticule and separating it out from the cap of the cornea, the lenticule. So the cap is separated from the lenticule. So you can see this lenticule is getting separated, and this is the edge of the optical portion. You can see the disc that had been created. Now you can see that we will go below the lenticule. So you can see this is the second layer where we are going below the lenticule. Once we have gone below the lenticule, we are now detaching it from the under surface of the cornea. What the femto has done, we are just breaking the bridges of the femto laser spots that had been done, and you can see that this is the creation of the lenticule, which will now just be pulled out. So you can see this is a beautiful surgery, again because of technology, because of very fine precision equipment of laser that we have, that you are able to now pull out this lenticule, this corneal tissue, from a 2 millimeter incision. So it is blade free and it is flap free. There is no flap that is created. Once you create a flap, you are cutting more corneal nerves and you get more dry eye. In this case, you don't do that, and therefore the dry eye treatment is much less. Smile offers very great outcomes, and you can do, as I told you, there is less dry eye symptoms. The other important thing is that even though when you have created a flap, the flap comes and sticks back to the cornea, it does not contribute to the strength of the cornea post-operatively. Okay, so, and this is the cleavage plane that is available throughout life. So even if you get somebody boxing you straight on the eye, that flap could get dislocated, or if you have some movement on the surgical movement. Now when you are doing smile, the lenticule is the only place which is going to reduce the biomechanical strength of the cornea. There is no flap. So therefore your biomechanical strength of the cornea is going to be better preserved. So less dry eye, better outcomes, and better biomechanical strength is the advantage of smile that you have. And then there are no flap related complications. These are flap related complications that you can have. So smile today is actually giving you better results, and mind you, all the companies are moving towards smile. We are personally involved in another company, the development of smile for them, and this is, I think, which is going to be the future for refractive surgery. Now let us just say that any patient who comes to you for refractive error has a limit in which you can do corneal refractive surgery. That means that the amount of tissue that you can take out from the cornea will depend on the starting thickness of the cornea and where you want to end. So there are certain things that you want to keep behind a bed of at least 275 or 300 microns. So if the power is very high, you do not do a subtractive surgery. When you are doing a laser vision correction, you are subtracting tissue. So it's a subtractive tissue. Rather, you do an additive surgery wherein you do what is called as an implantable polymer lens. Like a person wears a contact lens in the morning, takes it off. In this particular case, it is like a lens which is implanted within the eye. I showed you cataract, where you remove the lens of the person and replace it by an artificial lens. In refractive surgery of ICL, you do not take out the lens of a person, but just implant another lens within the eye which sits there. So if I have a power of say -12 or above, or -10 or above, or if I have a thin cornea, I will not do for a refractive surgery, but I will go for what is called as an implantable lens. You have now 3 companies in India which are doing these implantable lens. So this is an implantable lens which you have, and you can see that this has a vault. ये आपको दिख रहा है, there is a vault. So what this does is that when you put it in the eye, जो normal crystalline lens है, it does not touch the normal crystalline lens, so you don't get induced cataract. So you have this lens sitting on top of your normal lens, and that is how you can take away the refractive error. I'll just show you a small clip. So you can see in this particular case, the lens, this is the lens which comes out. So this is the size and shape of the lens, and you put it in an injector system. It is a very thin polymer lens, and you fold it. Once you have this put in the injector system, you just push it so that the lens is placed into the nozzle of the cartridge. Okay, once it goes into the nozzle of the cartridge, you can see this is the eye, and you will make a side port entry. I'll just fast forward it. Put viscoelastic. This is the main incision, which is about 3 millimeters. This is again a side port incision. And once you have put viscoelastic, you can see this is the lens. So this is the normal lens which is clear. Okay, so we are not wanting to touch this, and you can see that we are just implanting this lens very gently below the iris. This will first be put over the iris, but then we'll push it below the iris on top of the crystalline lens. So it is in the posterior chamber, below the iris and above the normal lens. And you can correct numbers up to -18 to -20, and you can also correct plus numbers. And in case you have powers more than -20 or -18, you can combine two procedures of LASIK and ICL. So that is called as bioptics. So you can go ahead and do this particular thing. So this is the, and this is, so there is the rotational chart. So now we have even toric ICLs where even cylindrical powers can be corrected in these. And this is what I told you is bioptics, which is a combination of two refractive corrections where you can do a laser vision correction as also an IOL. Now there is a third dimension that is coming, that sometimes rarely 1 to 2 in 10,000 eyes, which is 0.001%, post LASIK, the corneas did not withstand the insult of laser vision correction and the cornea could become ectatic. That means that the cornea would tend to bulge because of the IOP pressure. So to prevent this, as it is, the incidence is very low and we have become less aggressive in treating high power. So we remove less corneal tissue. The incidence has gone down, but there is a procedure which is called as corneal cross-linking, which we do for keratoconus patients. So this is the procedure that we are doing. This is called as LASIK extra.
During a LASIK procedure to preserve the corneal biomechanical integrity. A LASIK flap is created using a femtosecond laser or microkeratome. The flap is lifted. A normal excimer ablation is performed. Sufficient Vibex riboflavin is applied to cover the entire exposed corneal bed and allowed to diffuse. In only 60 seconds, Vibex penetrates the stroma to prepare for effective cross-linking. Excess Vibex is rinsed from the cornea using sterile saline solution. Removing excess Vibex helps to ensure proper riboflavin concentration in the cornea. The flap is repositioned as usual, and the Vibex then diffuses into it as well. With the eye now prepared, the UV beam is aligned in the X, Y, and Z axes using the KXL system's precise targeting lasers for cross-linking safety and precision. The Vibex is now exposed to the UV illumination through the flap and its intact epithelium to facilitate cross-linking. In just over 2 minutes, corneal cross-linking during a LASIK procedure to preserve corneal biomechanical integrity.
So basically what we are trying to say is that since we are weakening the cornea, whether it is in SMILE or in LASIK, and if we have susceptible cases or we feel that these cases could be borderline, we would prophylactically cross-link them by using ultraviolet light. Now again, you can see this is science combining dental. Dentist they use UV light when they are doing a filling. So they used to tighten the collagen there. So similarly, the same concept has come here, that you put riboflavin, this is a vitamin B, and that gets absorbed in the cornea and you shine UV light. So what it does is that the cross binding of the collagen fibers of the cornea gets excited and the tensile strength of the cornea increases. So on one hand, you are weakening the cornea by LASIK, but on the other hand, you are prophylactically strengthening it so that you do not end up with ectasia. So therefore, refractive surgery today has gone up by miles. You have SMILE, you have SMILE Extra, you have blade-free LASIK, etc. And today it is something. So this is the same. This is on a patient. You have a smile patient that is done. You can see that this is the smile. Again, I'm just fast forwarding it. You can see this is the lenticule that has been created. After the lenticule that has been created, you can see that the separation is there, and we are taking out the lenticule. And there you have, that is the separation, that is the lenticule that has been taken out. Now once the lenticule has been taken out, we shift the patient and we will just put the dye in. As you can see, we are putting the dye in. After we have put the dye in, soaked it for the required time, we will give the ultraviolet radiation, and we will be completing this procedure. So present indications are, if there are thin corneas or you're doing very high myopia or there is family history of keratoconus, etc., you can do this cross-linking. So friends, I've just given you a few videos to make it slightly more interesting and to show you as to where ophthalmology is. I think ophthalmology has lots and lots of technology that has come in. It has come in various other fields. I specialize in cataract and refractive surgery, and that's what I wanted to show you, that today cataract and refractive surgery, both cataract and refractive surgery, are taking us towards the goal of emetropia. That means freedom from glasses for the patients, trying to even get a better vision to a patient who was maybe wearing a +6 or a -6 before cataract surgery, getting him nearer to 0. So that is where we are. I think cataract surgery has become very high-tech, very sophisticated, and with great outcomes, changing from being a restorative to a refractive surgery. Thank you very much for your kind attention.